Welcome to AETCM, the emergency medicine channel. Shall I start? Present in the case of a 60-year-old male who came to ER with complaints of pain along the coronal sulcus in the penis, along with swelling of the foreskin, and he was unable to return the retracted foreskin back to the normal position since the last 2 days.
Okay. So penile region pain.
Yeah.
So what are difficulty in retracting the foreskin, right?
Yes.
So what are the DDs?
So this patient now came with the complaints of the pain mainly localized to the foreskin region. So we are suspecting it to be a paraphimosis. It could be a local cellulitis of the foreskin. So that's one of the possibility.
How to differentiate between phimosis and paraphimosis? What do you mean by paraphimosis?
Yeah, paraphimosis means it's a difficulty to return back the retracted foreskin. So that is the main, that is paraphimosis.
Retracting, return back the retracted foreskin, right?
Foreskin.
What do you mean by phimosis?
Yeah, phimosis means this is difficulty to retract the foreskin in its primary position.
So, what can be the causes for the same? That we'll discuss again later. What are the other DDs?
So the other DDs mainly involves in pediatric age. It could be a hair tourniquet syndrome. So hair tourniquet syndrome is one of the other causes.
Can you explain?
The hair tourniquet syndrome, the presence of a hair strand. So it is mainly getting strangulate around that region of the coronal sulcus. So that can cause localized edema along the glans penis, and which can cause pain and swelling. Along with the patient be having urinary symptoms, mainly that patient will be having increased frequency of micturition or possibility of urinary retention also. So these are the symptoms which can be present.
Then another cellulitis.
In cellulitis, mainly there will be present features of dysuria or fever. So it will be associated with it. Along with some patients can present with a discharge along the penile opening. So that is also another possibility.
Penile edema is there, no?
Yeah, penile edema.
Then priapism, how to differentiate between this one and priapism?
And priapism, usually in the cases of paraphimosis and all, there will not be a presence of constant erection. So the constant erection of the penis present is for more than 3 hours if it's said to be of a stuttering priapism. So that is one of the cause of
Fourniers gangrene. That anyway will be obviously will be able
by
to
discoloration. So
these are the most common DDs. Any other DDs?
Yeah, balanoprostatitis.
Balanoprostatitis.
So balanoprostatitis involves both the glans penis and also the foreskin. So that will be there will be presence of again dysuria and urinary symptoms. Increased frequency of micturition will be associated. There can be an associated epidermolysis also, along with the extension of the infection.
Okay. So these are the DDs. No, only this complaint was there, and no other complaints.
Other complaints was there.
Peripheral pulses, everything was valid. You can move it with the secondary survey. No, nothing in primary survey. Right?
Yes. So in this patient, so we asked the sample history. We have sample history. The patient was a 60-year-old male. He was a known case of type 2 diabetes. He had a history of benign prostatic hyperplasia. So he was having history of urinary retention 2 days back. So following which he was catheterized. But following it was catheterized outside hospital, but they forgot to bring back the foreskin in the original foreskin.
So what are the most common causes for priapism?
In priapism, usually one of the main phimosis. Paraphimosis. Yeah. In paraphimosis, mainly one of the initial cause could be an underlying phimosis itself. So that or underlying. Then next cause is usually in genitourinary procedures. So genitourinary procedures usually involves catheterization or cystoscopy procedures. So in such procedures also there can be a error. In that, there will be a mistake that they will not be bringing back the foreskin to its original position after retraction. So in such patients, the foreskin will remain retracted, and there will be a formation of a constricting band. So that will cause the further constriction along the coronal sulcus, along with the edema of the foreskin. So that's how the paraphimosis develops in such individuals. And that is another cause is patients having a penile trauma. So penile trauma is another cause. Usually if they're in Western world and all, we can see that body piercing along the foreskin and all. So that's procedures are there. That is another. Then another procedure due to be infection. So infection is another cause. So infection mainly involves in case of Plasmodium falciparum malaria. Falciparum malaria along with the monkeypox fever. So in monkeypox fever also there can be associated paraphimosis. So these are the features which are associated.
In our these days we are seeing mostly as iatrogenic as the most common
cause. And increased sexual activity also can. And the loss of personal hygiene. So reduced personal hygiene also can be one of the cause. So this individual, the patient was they had not retracted back the foreskin, so it had remained retracted for 2 days, following which this patient developed swelling with pain and edema across the foreskin. So this patient had no history of any dysuria or any discharge from the urethral meatus. There's no history of any hematuria, but this patient complains of increased frequency of micturition. No history of any urinary retention. But the main other associated complaint was increased frequency of micturition. No history of any lower abdominal pain. No history of any fever. No history of any vomiting. Vomiting also was not present in this individual.
What are the common signs and symptoms in cases of paraphimosis?
In paraphimosis, usually what happens is the sign we look for is the swelling. So mainly in the local examination along the penile region. So there will be edema and tenderness in the glans penis. Along with that, the patient will be having a painful swelling in the distal retracted foreskin. So that will be a localized swelling along the retracted foreskin. Along with that, there will be a constricting band of tissue. So that constricting band of tissue can initially constrict the lymphatic and venous system. Then if it still remains neglected, it contracts the arterial system, mainly the pudendal artery, and it will be involved, and then it will cause it can cause penile necrosis. So penile necrosis, it can also go into an auto infarction, so that complete tissue can get damaged. So that's how it can happen. And the important feature to differentiate from paraphimosis is that penis will be mostly flaccid, from priapism. So it will be the penis will be flaccid, and which is usually unaffected. The whole of the penis is not affected in case of paraphimosis.
So patient will be having swelling and pain, and later on will have necrosis, gangrene, right?
Yes.
Yeah. Then pathophysically, as you told, it will, initially there will be venous congestion, then later on arterial congestion and necrosis.
Okay. So this patient, after that, we had asked him what is the any allergy to medication. The patient was not allergic to any medication. We also asked the medication history. He was on tamsulosin, 0.4 mg. He was taking HS dose, and also the patient was on glimepiride and metformin. And the last meal was taken around 2 hours back. Local examination along the penile region for this individual showed edema and tenderness in the glans penis region. Along with that, there was a painful swelling in that distal retracted foreskin with mild local rise of temperature was also found. Along with that, there was a constricting band. It was present along the proximal to the head of the coronal sulcus. So it was present, and which was not able to retract on initial manual reduction. So then penile shaft was flaccid, it was not affected, and the glans penis was mildly firm on palpation. So this was the findings we got on local examination. Following the clinical features and the local examination, we came to a provisional diagnosis that a patient has paraphimosis. So we initially had tried to manually reduce the swelling. So that was the initial treatment which we started. We had asked for a lidocaine jelly. So lidocaine jelly was initially given applied over the penis. Initially we had using the rubber glove. We use it as a coating, and after that we apply the lidocaine jelly underneath. So we kept it for around 15-20 minutes for a local anesthesia effect. And then along with that, we had added glycerin. So glycerin was another compound which we used, and also we used sugar can also be used, but in our case we used glycerin, so that it can have a hygroscopic effect, so that it absorbs the water underneath the edema underneath, and so that it shrinks. And that we had kept for around 2 hours. And we tried to retract back the foreskin. So that was what the procedure we had tried to do. So what we did was we had grasped the distal part of the penis with the gloved hand. And usually what we do is we squeeze circumferentially. So the squeezing of circumferentially is basically we use the middle fingers to in the around the lateral aspects of the penis, and we tried to retract back the foreskin by keeping the thumb along the tip of the glans penis. So tip of the glans penis, and using the index fingers, we try to retract back by pushing it counterclockwise. The glans penis is pushed inwards, and the foreskin is pushed outwards. So we tried it and initially it did not improve. So then we had to ask for a urological consultation. So from the urologist side, they had come and they had asked for a Babcock forceps. So using the Babcock forceps, they had applied it as a in a 4-quadrant, around the 4-quadrant, 0 degree, 90 degree, 180 degree, and 270 degree. They had applied Babcock forceps, and then they had again tried for a manual reduction, and they succeeded and that manual reduction. So that was how it got relieved, and the patient got relieved of the symptoms and was kept for observation for 1 hour, and he was discharged. In paraphimosis, mainly the treatment involves pain management. So the first initial part is a pain management. The patient initially had a pain score of 7 out of 10. So we had given initially paracetamol, following which the pain had reduced a bit. And then next what we do is the steps to reduce the swelling. So the steps to reduce the swelling initially involves application of lidocaine jelly on local site. Along with ice can also be used. But ice, we must make sure it is not used for more than 15 or 20 minutes, because it can cause local ischemia along the site because of reduced blood supply. And another what we use is the hyperosmolar kind of agents. Example, granulated sugar or glycerin. We can also use 50% dextrose, 50% dextrose, and also even 20% mannitol. That can also be used for local application. So these are the substances which we use to reduce the swelling. Usually kept for around 1 to 2 hours. And we observe reduction in the size of the swelling. Along with that, we can attempt the manual reduction. So attempting the manual reduction, as I mentioned before, that is how the procedure is. Even after attempting of the manual reduction, it is not improving. Then we have traction with forceps. So we can use 2 forceps. One of the forceps is Babcock forceps. So Babcock forceps, we place the four forceps differentially along the circumferentially along 4 different angles. So 0 degree, 90 degree, 270 degree, and 180 and 270. So that's how it's placed, and then we again try to manually reduce it. And the next process is usually traction with the Adson's forceps. So Adson's forceps usually that also after local anesthetic application, we again try to reduce it back, but the position is different. One is along the 2 o'clock and 9 o'clock position. So only 2 forceps are required. If that fails, then we have to go for a dorsal slit traction. So that is another, we apply a slit along the dorsal part of the foreskin, and after that we again try to manually do the previous reduction. And if it's not, previously there was a method called as puncture technique. We apply using a sterile needle. We multiple times we puncture around all the the edematous part of the foreskin after giving a penile block, so that the patient does not feel pain. So after that, the swelling it gets manually reduced due to the increased the water will be removed off. Then again we can retract back. If all of these fails, the end what we do is the circumcision. So circumcision is the to avoid this, no? Yeah. Dorsal slit is the surgical management. Yeah, surgical management. Even if dorsal slit is not improving, then the last process is again a circumcision. So this is usually the treatment.
So if pain is not reducing, what will you
do? We can give procedural sedation for before manual reduction in such individuals, and also giving a dorsal penile nerve block is another.
Dorsal penile nerve block can be tried. Yes. How do you give dorsal penile nerve block?
In penile nerve block, we should avoid giving adrenaline, so that there can be causing of ischemia, and it is along the dorsal nerve, the nerve or the penis, and then it's usually what we use is 1% trinocate. We give it along the circumferentially. So and then we achieve the
dorsal penile nerve block. We are not giving circumferentially. Actually, we are giving on 2 sides. Okay. At 2 o'clock position and 10 o'clock position. We are giving at the dorsal region. We will give 2 injections at 2 sides, and that will block the pudendal nerves branches are there. These are being getting blocked, and later on we will be doing the any procedure, mostly dorsal slitting. And in we are giving the ring block, as you said, that is usually given for circumcision. That is the management regarding. But anything else you want to say? So mostly this, in cases of paraphimosis, the most common cause is iatrogenic cause, and once the patient comes, initially we have to manage the pain, later on we have to manage the condition itself. Mostly initially we will be trying with manual compression. If at all, we'll also try with hygroscopic methods, and if that is not getting reduced, we'll go ahead with the surgical methods, including dorsal slit and later on circumcision as the final management. Yeah.